Assalamu alaikum and welcome everyone to today's webinar, which is about inflammation at the heart of cardiovascular disease. We will focus on unmasking inflammatory risk in a patient with atherosclerotic cardiovascular disease and CKD. So despite why it's important, because despite significant advance in the cardiovascular care, many patients with atherosclerotic cardiovascular disease and CKD continues to experience cardiovascular event, and highlighting the importance of residual inflammatory risk as the key driver of a disease progression. So today we will explore the role of inflammation in the cardiovascular disease, the importance of identifying patients at increased inflammatory risk, and emerging the opportunities to address this unmet need. So before we start the presentation, I will share my slide to present some important data. So today the talk will be about inflammation at the heart of the cardiovascular disease, and I would like to disclose my potential conflict of interest and warmly and welcome our distinguished speakers, Dr. Sharma and Dr. Juwaria Al-Ali. Dr. Sharma is a cardiologist and assistant professor and clinical scientist in the Division of Cardiology at McGill University. And his clinical and research expertise lies at the intersections of cardiology, digital health, and epidemiology with a focus on heart failure and diabetes. The second speaker, Dr. Juwaria Al-Ali, she's president of the Emirates Cardiac Society and the first woman in the Arabian Gulf to hold this position. She also serves as a board member of the World Heart Federation and leads at the Heart Failure Clinic at Rashid Hospital. And she's a director of the Cardiology Fellowship Program at Dubai Academic Health. So cardiovascular disease is the leading cause of death globally. And in 2023, cardiovascular disease were responsible for approximately 20 million deaths worldwide, that affecting approximately 650 million people, and that generating the substantial economic burden. And even with the traditional risk factors such as LDL cholesterol and the other risk factor, many patients continue to experience recurrent cardiovascular event. That's growing. The evidence shows that residual inflammatory risk is an important and modifiable contributor to this ongoing risk. So let's welcome Dr. Sharma to explain the unhidden inflammatory risk in atherosclerotic cardiovascular disease and CKD, and we'll discuss the very important and the recent global study that showed the prevalence of inflammation in the cardiovascular disease. Dr. Sharma, the floor is yours. I will stop sharing my slides. Now you can share your slides, Dr. Sharma.
Thank you so much. Assalamu alaikum, and thank you so much for having me here to present to you today. It's a great honor and a great privilege to be speaking to you on this very important talk on inflammation. So I'll just share my slides now, and I'm going to set a timer for myself because I love to talk. So I just need to make sure that I'm right on track here. Great. Okay, so the first part of my presentation will be looking at the hidden fire in ASCVD and CKD, so atherosclerotic cardiovascular disease and CKD, chronic kidney disease, and really to understand inflammation and the risk that inflammation poses to our patients with these comorbid conditions. My name is Abhinav Sharma. I'm an assistant professor, actually associate professor in the Division of Cardiology at McGill University in Montreal in Canada. Here are some of my disclosures, and of course, this talk was sponsored by Novo Nordisk. Thank you very much for hosting this to Novo. So we'll be looking at cardiovascular inflammation and its role in ASCVD and chronic kidney disease. We'll talk about high sensitivity CRP as a clinically actionable and predictor of CV events. We'll talk about guideline recommendations for measuring hsCRP and anti-inflammatory therapies for secondary prevention and what's in the pipeline to come. So let's talk about CV inflammation and its role in ASCVD. What is CV inflammation? Cardiovascular inflammation, as we know, inflammation is a very broad term, but cardiovascular inflammation is a cytokine-driven process mediated through a molecule called interleukin 6. And this drives cardiovascular specific adverse pathophysiology and adverse clinical outcomes. Now, the challenge with interleukin 6 is that it's very hard to measure interleukin 6 in practice, and we'll talk about that. But associated cardiovascular risk by inflammation can be measured by a molecule called high sensitivity CRP, which a lot of us are very familiar with. And the threshold that seems to arise is a CRP above 2. And we'll go into this in much more detail. Let's walk through the pathophysiology. And this is a very busy slide, but please look from your left of the screen to the right. We see that risk factors and additional stressors like high LDL, high blood pressure, potentially trauma, previous exposures can all cause increase in LDL levels and increase in the turbulent flow going through blood vessels. This leads to LDL entry into various components of the vessel wall and results in oxidation. This oxidation triggers immune cells because the body thinks that there's something happening, some sort of infection or some sort of trauma happening. But that chronic exposure of immune cell results in the creation of a foam cell. And this foam cell produces a necrotic core, which then can potentially rupture. So it's a very busy slide here, but essentially you have risk factors like high cholesterol, like high blood pressure, and how that influences and interacts with vessels and then goes into the sort of foam cell here. The key point is that within myeloid cells, so within immune cells, okay, there's this protein complex called NLRP3. And this complex produces the interleukin 6 that drives future cardiovascular risk, or it's associated with increased future cardiovascular risk. Let's look at this in a bit more detail. NLRP3 inflammasome is activated when we have high blood pressure, high cholesterol, hypoxia, activation of neutrophils through this complex cascade, which we spent a full hour going through this, but essentially this, through many cell types, will activate and release interleukin 6. Interleukin 6 is a pro-inflammatory cytokine associated with atherogenesis and plaque rupture. Interleukin 6 goes to the liver, and the liver produces CRP. And it's that CRP that we're able to measure clinically. Interleukin 6 has been associated with both the development and progression of atherosclerotic cardiovascular disease. In the physician health studies and clinical trials, higher levels of interleukin 6 were significantly associated with CV risk in primary population, so those without previous ASCVDs, and secondary population. So we see that across the spectrum, interleukin 6 is a key molecular driver here, or key molecular associate of future atherosclerotic cardiovascular disease. Now, we talked about ASCVD, inflammation, interleukin 6, but what about chronic kidney disease? We know that chronic kidney disease is associated with an increased state of inflammation. As the kidney function deteriorates, inflammation starts to ramp up, and this is associated with an increased risk of ASCVD by itself. 50% of deaths in patients with CKD are due to cardiovascular disease. Okay, so half of these people are not dying from kidney dysfunction, but they're dying from cardiovascular events. And potentially why may be a mechanism? Well, CKD is associated with increased inflammation, increased IL-6. So the kidneys, as it fails, increases inflammation, drives systemic inflammation, and increases the risk of future cardiovascular events. If you see the box on the right here, increasing levels of IL-6, remember the circulating cytokine produced by the NLRP3 inflammasome, are associated with an increased risk of cardiovascular events in patients with chronic kidney disease. In patients with ASCVD and CKD treated with statins, systemic inflammation appears to be a greater predictor or greatly associated with recurrent CV events than even high LDL levels. Let's talk about hsCRP. So I've mentioned that interleukin 6 goes to the liver. The liver produces hsCRP. Okay, so let's look at hsCRP as itself as something that's clinically actionable, because a lot of us are familiar with hsCRP. We often use it as a way to track inflammation with infections, but it's a little bit non-specific. But let's take a look at that in more detail. C-reactive protein, CRP, is an acute phase protein that has been established as a biomarker of cardiovascular risk. We know that CRP is an acute phase protein produced by the liver in response to circulating cytokines like IL-6 during injury or inflammation or infection. Mechanistic and genetic studies have shown that CRP is a robust and a strong biomarker of CV risk without a causal role in the pathogenesis of the disease. For risk assessment, CRP, we use the high sensitivity CRP to be more precise in our CRP risk, in our cardiovascular risk assessment. So to put the picture together, for cardiovascular disease, risk factors, traditional and novel risk factors, drive the production of interleukin-6. Interleukin-6 goes to the liver and produces CRP, and it's that CRP that's the end readout of a whole cascade of inflammatory pathways. High sensitivity CRP assays are used to detect trace amounts of CRP protein that are associated with CV risk. We know that hsCRP are used to measure trace amounts of CRP. This is CRP in the blood and this can be done during any type of cardiovascular risk assessment. And this assay has superior precision, accuracy, and standardization. And generally speaking, globally, whenever you measure hsCRP in one region, you can compare it to another region. Standard CRP assays are used to assess CRP increases, so if it's very, very high or very low. But hsCRP is actually the more sensitive and more appropriate test when we're looking at CV risk. hsCRP greater than 2 milligrams per liter indicates high inflammatory risk associated with adverse CV outcomes. So across multiple studies, we've seen that hsCRP more than 2 is associated with an increased risk of future events, both in the high-risk primary prevention population, but also even in the secondary prevention population. And in hsCRP in the 2025 ACC scientific statement indicates because clinicians will not treat what they do not measure, universal screening of hsCRP in both primary and secondary prevention patients in combination with cholesterol represents a major clinical opportunity and is recommended. Among individuals receiving statin therapies, consideration should be given to increase dosages. So the question is, what do we do if the CRP is high? Amongst individuals receiving statin therapy, what we could do is to consider to increase the dosage into the high intensity range of CRPs elevated. And why? Because hsCRP is at least as powerful a predictor of recurrent vascular events as that of LDL-C. Okay, so this inflammatory protein is as predictive for future cardiovascular events as the cholesterol measures. High hsCRP levels are associated with increased risk of all-cause death in both primary and secondary prevention settings. I won't go through this in a lot of detail, but multiple countries, multiple regions have tested this. hsCRP is a more powerful determinant of CV death than LDL cholesterol in statin-treated participants. This is a collaborative analysis from Prominent, Reduce It, and Strength. So multiple trials have shown that hsCRP more than 2 is just as strong of a predictor as having high cholesterol. And of course, with future CV risk, as we see the CRP increase, LDL may not necessarily see that increase in risk, but CRP, we do see increased risk of future adverse events. hsCRP and LDL-C are predictors in CV mortality in statin-intolerant patients. So these are patients in the CLEAR outcome trial, right? So we see almost in 13,000 people as hsCRP is elevated, risk of future events increases over time. And hsCRP appears to be maybe a better predictor of MACE in CKD compared to LDL cholesterol. So when they looked at a large sub-study of a big trial called CANTOS, we see that hsCRP appears to be a better predictor in terms of the CRP, in terms of adverse cardiovascular events than some of our more traditional factors like LDL cholesterol. Okay, so when we look at the right side of the screen here, you see CKD and ASCVD, both combining together to create inflammation. And with high hsCRP and high LDL, it does associate with increased MACE. But when we look at the patients with CKD, for example, hsCRP is associated with higher risk. But when we look at the LDL, not as associated with risk. So it does provide this hypothesis that inflammation is associated with future atherosclerotic cardiovascular events. So this is what we're talking about, uncovering that hidden inflammation. In randomized trials, 46% of patients have inflammatory risk despite lipid management. So despite the fact that you can control the cholesterol, the inflammatory risk remains high. Okay, so the cholesterol risk is elevated in this patient population. High inflammatory risk was identified in 46% of patients after high-intensity lipid-lowering therapy. So high risk, CV risk remains after optimal statin therapy. We see data from 11 large prospective statin trials, and we see that overall, we have various studies showing that with statin therapy, you do indeed reduce the risk of future atherosclerotic events, but the residual risk of events still remains high. And this is across multiple studies. So statins are great for reducing risk, but there's still a lot of risk that's there amongst these patients. Now, in the last 8 minutes for this, we'll go through the guideline recommendations for measuring hsCRP. The 2025 ACC Scientific Statement on Inflammation identifies hsCRP for inflammatory risk associated with CV disease can help guide statin intensification. So among appropriate patients in both primary and secondary prevention, universal screening of inflammation was recommended through hsCRP. hsCRP adds prognostic information on CV risk comparable to that of blood pressure and cholesterol. hsCRP is at least as powerful predictor of recurrent vascular events as that of LDL-C amongst individuals with CV disease. Among individuals taking statin therapy, consider dosage increases if hsCRP levels remain greater than 2, irrespective of LDL cholesterol. Oops. When we go through the 2024 ESC guidelines for the management of chronic coronary syndromes, we see that additionally hsCRP and or fibrinogen plasma levels should be considered as a 2A indication amongst individuals who may have chronic atherosclerotic cardiovascular disease for risk stratification. So the 2025 statement aligns with the 2024 European guidelines. It's a very busy slide here, but that's something to consider. And of course, we know that even from older guidelines that have been updated, the 2025 focus update of the ESC guidelines, we see that persistently elevated high sensitivity CRP greater than 2 milligrams per liter. We have elevated, adds to prognostic value, prognostic utility. Now, finally, we'll look through the anti-inflammatory therapies for the secondary prevention of CV events. So hopefully I've convinced you that inflammation is important and measuring CRP is an important aspect. Okay. So now we have IL-6, interleukin-6, coming through the liver. Liver produces CRP. That's what we're measuring. Anti-inflammatory therapies for secondary prevention is what we will be looking at next. So we've seen that there's been a number of trials evaluating novel molecules that block various aspects of the NLRP3 inflammasome. You have the IL-1 inhibitor. Okay, so this is looking at interleukin-1, ASCVD. Canakinumab was one of the first that's been tested. That's a specific kind of blocker here, and anakinra has been used in other populations. There's other anti-IL-6 receptors as well, such as tocilizumab and others. You may remember tocilizumab because it came up during a lot of the COVID trials and infections. And now we have anti-IL-6, which are being tested in clinical trials, which blocks the IL-6. So there are multiple molecules that are now targeting different aspects of the NLRP3 inflammasome pathway. CANTOS, COLCOT, LEDOCO, and CERT trials, again, very, very busy slide here, but multiple trials have assessed the effect of targeting different components of the NLRP3 inflammasome pathway. Okay. So, for example, canakinumab, which was the one testing the anti-IL-1 beta, reported a 15% reduction in the risk of the composite cardiovascular endpoints. COLCOT, which tested colchicine, you remember colchicine from gout, was actually retested as an anti-inflammatory molecule, reported a 23% reduction in the primary cardiovascular outcomes in a variety of trials. Unfortunately, the methotrexate trial that did not demonstrate that low-dose methotrexate could reduce the risk of composite endpoints here. And the results of all of these support the local inflammatory hypothesis. Okay. The methotrexate doesn't, but more specific targeting does help support the inflammatory hypothesis. So what it means is that inflammation is associated with increased adverse cardiovascular events. We can accelerate statin treatment or enhance statin treatment. And these older trials and other trials have shown that blocking different aspects of the NLRP3 pathway is actually beneficial. So in the final few slides here, just a little bit about ziltivekimab. This is a human IgG1 monoclonal antibody directed against the IL-6 ligand. It is an anti-inflammatory agent administered once monthly as a subcutaneous injection. Okay. This is going to come through as CRP. So remember, myeloid cells produces IL-6, goes to the liver, produces CRP. Ziltivekimab is an IL-6 inhibitor, so it blocks this element of the pathway here. There was a phase 2 dose-finding trial called Rescue. This looked at 264 patients with stage 3 to 5 CKD, high sensitivity CRP greater than 2 milligram per liter, demonstrating that compared to placebo, it looked at higher and higher doses of ziltivekimab. And the primary endpoint was to look at the change in the CRP. So the idea was that by blocking IL-6, can you reduce CRP? The hypothesis should be that ideally you would. And secondary endpoints looked at other inflammatory markers as well. This was a 12-week on-treatment analysis. And overall, within this rescue trial, ziltivekimab significantly reduced hsCRP levels and other biomarkers of inflammation compared to placebo in the rescue trial. Median changes from baseline with ziltivekimab at 15 grams at 12 weeks demonstrated a reduction in hsCRP of 88%, so very substantial reduction, a reduction in fibrinogen levels, a reduction in other inflammatory molecules as well. So ziltivekimab achieved significantly reduced hsCRP levels compared to placebo. Okay. And there were significant reductions in inflammation biomarkers over time. Ziltivekimab was generally well tolerated, and infection-related adverse events were comparable to the placebo groups. Very low rates of neutropenia. The infections risk was balanced between two arms because, of course, whenever you have an anti-inflammatory, you may be concerned about increased risk of infection as well. And few mild or injection site reactions were reported. This leads to the larger trial, the ZEUS trial, a randomized, parallel group, double-blind, placebo-controlled, active trial. Looked at hsCRP over 2, looking at established ASCVD, and those with CKD. So now I'm going to loop it back to the beginning, right, where ASCVD plus CKD combined together, just high-risk population, randomizing to ziltivekimab versus placebo. The objective is to demonstrate superiority of ziltivekimab, and the primary endpoint is the time to first occurrence of these endpoints. And there are a number of secondary endpoints as well. Like I mentioned, so this is a phase 3 outcome looking at clinical events. Rescue, which I showed before, was looking at CRP. Very broad representation from across the world. 76% came from cardio, 14% nephro, 38 countries, and over 6,000 participants. So just to summarize, despite advances in the treatment of CVD, ASCVD remains the leading cause of death, particularly in people with CKD. CV inflammation, especially mediated by anti-IL-6, leads to adverse CV and renal outcomes. Despite standard of care, globally, up to 50% of people with ASCVD and CKD may show evidence of CV inflammation. So this is really the key here, is this hidden inflammation. Treating CV inflammation by targeting IL-6 inhibition may reduce the risk of MACE, CV death, and CKD progression in people with atherosclerotic cardiovascular disease and CKD. The phase 2 rescue trial was very encouraging, and the idea is does ziltivekimab have the potential to be the first in-class IL-6 inhibitor targeting CV inflammation? So with that, I think I'm right on time. Thank you very much. So that sort of ends my first talk. And if I understand, I will go right to the second talk here. Give me a few moments. Okay, great. So now we have, I'll go into the second part of the talk here. So in the first part of the talk, I want to focus the lens on the pathophysiology, on the mechanisms, looking at CRP, and trying to understand where this pathway is going. We also reviewed very briefly the therapeutic options that were available for these individuals and the emerging ongoing clinical trials. For this phase here, what we're going to be focusing on is revealing the inflammation, who is inflamed, and what actually is the burden of inflammation. Because it seems like the residual risk is very high, even though you treat people with statin therapy. But how many individuals overall are truly still inflamed? So let's look at background, objectives, and study design. So POSEIDON is a large global cross-sectional study examining the prevalence of CV inflammation in ASCVD with and without CKD and heart failure. Globally, ASCVD and heart failure affects 500 to 64 million people, respectively. HSCRP is a well-established marker for inflammation and CV risk, as I just told you, and limited evidence exists regarding the prevalence of CV inflammation. POSEIDON, therefore, is a cross-sectional global study trying to look at the generalizability. The patients where most severe disease were excluded, so we didn't want very, very sick people, but trying to look at the prevalence of this disease. And this included 18,000 people from over 18 countries. So POSEIDON, like I said, it's a cross-sectional study. So Zeus, that I mentioned before, was a prospective randomized controlled trial. This was a prospective study here. 18,000 people diagnosed with ASCVD and or heart failure. What we wanted to see is what were the estimates of the prevalence of CV inflammation in these predefined cohorts. So we have 12 months of medical history. You have ASCVD with CKD, ASCVD without CKD, HFpEF and heart failure with mid-range, and HFrEF. So a broad group of people that were included in this cross-sectional study. And the primary objective was to estimate the prevalence, how many people were inflamed, and then they also looked at additional markers like interleukin-6, NT-proBNP as well. It was a global study conducted across 18 countries. And so for this particular talk here, for the next 20 minutes or so, I'll be focused on the POSEIDON ASCVD cohort, looking at patients with and without CKD. There's a high prevalence of CV inflammation in the ASCVD cohort. In the POSEIDON study, the primary endpoint was high sensitivity CRP as a measure of the prevalence of CV inflammation. 39% of patients in the ASCVD cohort had CKD. Let me restate that. The top line results were that CV inflammation was observed in 39% of individuals with ASCVD and CKD. And CV inflammation was observed in 28.3% of people in the ASCVD cohort without CKD. So very, very high prevalence of CV inflammation observed globally amongst this high-risk cohort of ASCVD plus CKD, and even in those individuals with ASCVD but without CKD. The prevalence of CV inflammation was highest in the US and lowest in Japan. And we see a big distribution of the proportion of individuals who have atherosclerotic cardiovascular disease with CKD and atherosclerotic cardiovascular disease without CKD. So you can see the United States has the highest prevalence of elevated hsCRP. The prevalence of CV inflammation was highest in the US and lowest in Japan. Okay, so sort of reiterating what we saw there. It's a very busy slide, so I'm not going to spend too much time on this right now. But now, the prevalence of high inflammatory risk subgroups. Okay, when we looked at demographics and lifestyle, let's walk through what was a CRP in those individuals. Okay. When we looked across the spectrum of age in general, the light red is ASCVD with chronic kidney disease. The dark is ASCVD without chronic kidney disease. And we see that overall, age doesn't necessarily imply higher inflammation. Maybe there's a slight increase in those above 85, but it's not that high. Females appear to have higher levels of inflammation, interestingly, compared to men. Those with peripheral arterial disease appear to have a higher level of inflammation. Here, the strong factor here is greater than 1 pack per day of ASCVD with CKD group. When we look at the inflammation, smokers appears to be the highest risk of having high levels of inflammation, which is not surprising. Okay? And of course, as EGFR is declining, we see a rising level of inflammation burden in that particular patient population. So POSEIDON predominantly enrolled patients with CKD stage 3 in the ASCVD with CKD cohort, indicating a very high renal burden. Okay, so this was a sicker population. 59% of them had CKD stage 3. High use of standard therapies in the ASCVD cohort with and without CKD. Okay, so they had good therapies overall. 87% of these individuals were on statins. 34% of these people were on ezetimibe. 1% were on colchicine. Okay, so small numbers, but statin therapy, ezetimibe use was very reasonable. Even 39% were on SGLT2 inhibitors, okay, and 5.1% in those individuals to 6.7% were on GLP-1. So a good mix of guideline-directed medical therapy overall. And despite that, there was still a high prevalence of inflammation. So amongst individuals who were using statins, you still had almost 40% of individuals, 37%, had high levels of inflammation. Same thing for PCSK9 inhibitors. Same thing for GLP-1 as well. Okay. Higher prevalence of CV inflammation were seen in patients with a higher BMI. This is not surprising, given what we know about inflammation, the burden of inflammatory disease, and the impact specifically of visceral adiposity on inflammation. It's not surprising that individuals at the highest BMI category have the highest rates of being inflamed. So we have ASCVD with CKD. When you look at those who are underweight, it was around 32%. Around normal weight and overweight, it starts to go up at 33, 38. And then amongst people whose BMI is greater than 30, you have a 49% increase in the risk of obesity. ASCVD without CKD, we see the same thing. That higher levels of of CRP is identified in those individuals who have a higher BMI. What's also very important, let's tie it back to the mechanism, to the hypothesis. We mentioned that inflammation driven by interleukin-6 goes to the liver, produces CRP. Higher IL-6 levels were observed in the ASCVD with CKD cohorts. In the POSEIDON study, the secondary endpoints were levels of inflammatory biomarkers. Example, IL-6, and this was stratified by hsCRP. So remember that IL-6 and CRP are very correlated. Now, let's take a look at IL-6 overall. Now, unfortunately, we don't necessarily have good thresholds or understand a clear threshold of IL-6 and risk. But when we look at median IL-6 levels in people who have ASCVD and CKD, it's not surprising that if your CRP is elevated, you're going to have high levels of interleukin-6. Same thing for individuals without CKD. If you have high levels of CRP, your median IL-6 levels are higher. So this helps to confirm that molecules and markers that we can measure in the clinic are associated with high levels of interleukin-6, which we see otherwise. Okay. And hsCRP and interleukin-6 were moderately and consistently correlated across ASCVD populations. And this was independent of CKD status. What does that mean? Well, we want to see that interleukin-6 and CRP are related. So if you have higher levels of interleukin-6, you should have higher levels of hsCRP. What we see overall is that the correlation coefficient, which defines how closely they're related, shows that IL-6 and hsCRP have a rho coefficient of around 0.55. When we look at individuals without CKD, it's about the same. This implies that there is a correlation, and a reasonable correlation, independent of CKD status, of interleukin-6 and hsCRP. So they are correlated. So as IL-6 goes up, hsCRP goes up, which is anticipated. But it's good to see that again. And these findings suggest that hsCRP and IL-6 represent a shared inflammatory pathway across cohorts. Patients with ASCVD with CKD had more comorbidities and higher levels of CV inflammation. HFpEF was a big focus, but looking at T2D, obesity, rheumatic autoimmune, hypertension, liver disorder. When we see ASCVD with CKD and ASCVD without CKD, okay, we have 5,000 and 7,000. As I mentioned in the beginning of the study, 39% of the individuals in the CKD cohort had high CRP. In the patients with ASCVD with or without CKD were generally, as I shown in the previous slides, were generally very well treated with high use of standard therapies. And let's dig into these numbers here. It's really small numbers, but I just wanted to highlight these to you because I think that is going to be very important overall. If you have a person with HFpEF, among those individuals with ASCVD and CKD, the prevalence of inflammation was high. Okay. But what we see is that there's a high prevalence of the comorbidity burden as well in this patient population. So what we're seeing is that patients with ASCVD and CKD have a comorbidity burden that may also be contributing to their inflammation. We see the same for HFpEF, T2D, obesity, a high prevalence of these comorbidities in those patients with CKD and without CKD. And as we mentioned, the CKD population has this high CV inflammation risk. The big thing was that hypertension was highly prevalent across all subgroups. Patients with ASCVD and CKD had a very high proportion of hypertension, even if their CRP was low or CRP was high. Same thing for ASCVD without CKD. And when we do independent risk factor modeling, what are the features most associated with CRP? It's the common features that we all understand. Smoking. More than 1 pack a day of currently smoking was associated with the highest risk, okay, of independent risk factor for high CRP. Same thing for obesity. BMI greater than 30 associated with high risk of high CRP. Lower EGFR, higher LDL. Okay. So all of these are independent risk factors for hsCRP over 2. So where do we stand? Okay, looking across all of these messages, if we think about the key messaging that POSEIDON tells us, what is it? That number one, there's a high prevalence of CV inflammation in ASCVD with or without CKD. 39.3% of people with ASCVD with CKD have high CRP. Even those without CKD, there is still a high prevalence. 28% of individuals with ASCVD, even though they do not have CKD, are inflamed. That's number one. Number two, in patients with ASCVD, with and without CKD, generally they were still very well treated on different types of therapies, okay, and higher use of standard therapies. But despite that, we see this high risk. The third is a high inflammatory burden in the ASCVD with CKD cohort compared to the ASCVD without CKD cohort was identified. So when you combine together ASCVD and CKD, inflammation markers appear to be more elevated. Number four, in the CKD patients with ASCVD, with CKD, and higher CRP levels, these were associated with worse renal profiles. Okay, so that those individuals that are more and more inflamed tended to see higher worse renal risk profiles, so lower eGFRs. Number five, the high prevalence of CV inflammation appears to have a correlation between IL-6 and hsCRP, supporting the need for routine assessments of inflammatory markers. And overall, the final sort of combined message here is that 2 in 5 participants with CKD and ASCVD had CV inflammation, so high CKD or high hsCRP. So I think this slide just basically recapitulates what I was mentioning. POSEIDON was a very large global study. It's a very high quality study that provides complementary global estimates. CV inflammation is common, affecting 2 in 5 patients with ASCVD and CKD. IL-6 levels were higher in ASCVD with CKD, and hsCRP and IL-6 were consistently correlated. There was a high burden of comorbidities in the ASCVD population, and despite the high level of inflammation, we may think that they're untreated, but actually there was a high use of standard therapies. And finally, this provides more evidence of the hidden inflammation that may be there amongst our patients. And this may be things that we need to search for and look for to identify who is at higher inflammatory risk. As I mentioned in my first presentation, high CRP is associated with an increased risk of adverse cardiovascular events above and beyond other markers, okay, like lipids. So with that, I think I'm even a few minutes ahead of time, which is always great. Thank you so much, and look forward to the future presentation and the discussion. Thank you.
Thank you, Dr. Sharma, for the very informative presentation. Now we'll move to the second speaker, Dr. Jwari Al-Adi, who's going to present or talk about from the evidence practice and if it's the time to routinely measure the high sensitivity CRP. Welcome, Dr. Jwari.
Yeah. Thank you, Dr. Nadia, and thank you, Dr. Sharma. We made my job much easier. I'm actually gonna just mention things that you actually mentioned, but it's only to make it like more emphasize it and make it more practical for people. So for our audience, there's gonna be audience response questions here. So please participate, because I'm also curious to see what everybody thinks about these questions. It's going to be in the form of questions, and all these questions are very common. We've been asked these questions in multiple sessions that we did for secondary prevention and for dyslipidemia management. As we talk more about hsCRP, the questions come. So that was the whole idea of this presentation, is to address these questions. So of course, I was engaged by Novo Nordisk to give this presentation. So why do we measure CRP and not interleukin-6? I don't know if Dr. Sharma mentioned this, but he showed the inflammation cascade, and what we're targeting is interleukin-6, but the downstream of it is high sensitivity CRP. And the reason we don't measure interleukin-6 in clinical practice is because it is a poor clinical biomarker. The problem with it, it has a very short half-life. It has diurnal fluctuations, so it can go up and then go down again. And there isn't a widely available standardized assay. So if you want to measure it, you might get a different value in the morning than a value at night. So it's going to be very difficult to use it, clinically. Whereas CRP is standardized, it's validated, and it's a stable biomarker. So if you do the test here versus you do it in Canada, it is the same, and it's widely available. So this is the reason why we measure CRP and not interleukin-6. So this is an audience response question. So which high sensitivity CRP threshold is currently considered the most clinically validated cutoff to estimate risk in patients with established ASCVD? Is it more than 1 milligram, 2 milligram per liter, 3 milligram per liter, or 10 milligram per liter? I'll give you a few minutes to submit your answers. Not a few minutes. I'll give you a few seconds to submit your answers. So if the team in ICOM, because I cannot see the count, so I don't know if, how many people submitted answers. Okay, so here we got the, do you guys see the answer? So the majority of you actually got it right. So 60% said more than 2 milligram per liter, and then the others chose different numbers. So let's look at, so this was mentioned in Dr. Sharma's talk. So more than 2 milligram per liter is what's clinically validated. This is recommended from large epidemiological cohorts, randomized controlled trials, and it is the cutoff used in all other trials. So Countess, Jupiter, Prominent, Reduce It, and Strength studies. It is the cutoff where there is significant risk of MACE, cardiovascular death, all-cause death, with more than 2 milligrams. And it is what's mentioned in the ACC scientific statement to be considered a high risk. Now, less than 2 is not normal. What's normal is less than 1. So there is a slight gradient there between 1 and 2, but more than 2 milligrams per liter is what's considered high inflammation with the current information that we have. Okay, so this is another question. Who should be tested for high sensitivity CRP? Is it patients with recurrent coronary events, patients with heart failure, patients with ASCVD and CKD, or should it be for all patients with established CVD? So please vote. We should have put some music here, so, so it's smooth for everybody.
That's right.
So do we have some numbers?
I don't personally see the numbers, but I don't know if someone else can. But
no, not yet. So ICOM, do you have numbers? Okay, here we go. So all patients with established CVD, so 60% got it right. And then the others, they were not wrong. So, I mean, all the other patients do require having high sensitivity CRP. But the reason we want to do it for all patients with established CVD is because, I can't move the slide. Here we go. It's because, first of all, this is the recommendation. Everybody should get it done because you need to estimate the risk of the patient. So this is the problem sometimes when we're still at the beginning of understanding the risk and understanding what can we do for patients. The question that always comes up, so I do high sensitivity CRP, so what does that change for my patient? It does make you estimate the risk better. So a patient who had a coronary event and has a normal high sensitivity CRP is lower risk than the patient who had a coronary event and have a high sensitivity CRP. So this is the reason why you do it. And then after someone just jumped into the next question, so we're not there yet. So this is the reason why you do it, and it has to be done on all patients. Of course, patients with recurrent event, there is more reason to do it. Patients with heart failure, there's more reason to do it. Patients with CKD, there's also more reason to do it because we know that they're more likely to have a high sensitivity CRP, but ideally it should be done to every patient with a previous ASCVD. So next question. So this question always comes up. How many times you should do high sensitivity CRP in a patient to detect cardiovascular inflammation in patients in secondary prevention? So specifically patients who had events, how many times you should do it? 1 time, 2 times, or every 6 months? Oh, interesting. So 63% said we should do it every 6 months. 21% said we should do it 2 times, and 17% said we should do it 1 time. Okay, so let's see. So you should do it 1 time. So the reason this question comes up is because there was a previous recommendation, I think from the AHA, that it should be done twice. And that's to confirm the elevation. So you do it once, and if it's elevated, you repeat it after 2 weeks to make sure that it's really elevated. So that was an old recommendation. You don't really need to repeat it because if it is high, it's going to be high unless the circumstances change. So for example, if you're doing it in a patient today and you had a high sensitivity CRP, and the patient is obese and he has diabetes and he has all other reasons that will make cardiovascular inflammation common. So you did counseling for this patient and you told him, well, you need to lose weight. Maybe I'll start you on a GLP-1 receptor agonist. And then this patient, because you told him about the risk of inflammation and a risk of recurrent events, became too serious about lifestyle changes and too serious about losing weight. And then he comes to you a year later where he lost significant amount of weight, he's not obese anymore, then yes, that patient needs to have a repeat high sensitivity CRP because the circumstances changed. His risk has changed overall. And maybe his inflammation went down. But in general, just to repeat it every 6 months is not going to give you additional value. Now, another, I think that question came in the chat. We're going to address it later. But someone was saying, well, maybe someone has an infection. Maybe this is a reflection of an infection. So generally, if it's an infection, the numbers are not going to be 2 or 3. The numbers is going to be more than 10. So if you have a high sensitivity CRP more than 10 milligrams per liter, then yes, you should repeat it after 2 to 3 weeks, even if there is no obvious sign of infection, because probably there is a lingering infection. These numbers are not numbers of the significant of cardiovascular inflammation. That's more of an inflammatory process that's going on. And you might consider repeating it in primary prevention because then you're not sure really, like the patient did not have an event. It does not have all the risk factors to lead to a elevated high sensitivity CRP. So you might consider repeating it. But generally, the recommendation from the current guidelines is to do it once and no need to repeat it unless the situations that I mentioned. Okay, so this question, a patient with established ASCVD has had a stable high sensitivity CRP results of 3.5 milligrams per liter. No evidence of infection of recent trauma. How should this result be interpreted? Do you consider this a normal result with no clinical significance? Do you think this is acute infection, requires repeating the test? Is it indicative of cardiovascular inflammation and an increased residual cardiovascular risk, or it's only relevant if LDL cholesterol is elevated? So let's vote. Okay, very good. 83% say this is indicative of cardiovascular inflammation. So this is correct. So I don't have to spend a lot of time on this slide. But as I said previously, acute infection, high sensitivity CRP would be more than 10. Anything between that, between 2 and 10 is an indicative of chronic infection and chronic inflammation, chronic sustained inflammation. And the cutoff, as we said, is more than 2 for cardiovascular inflammation. Okay, so patient is hospitalized with an acute MI, and high sensitivity CRP is measured so within 48 hours, and it was 12. So now, what is the most appropriate interpretation? Does the patient has confirmed residual inflammatory risk, or does the result will guide long-term treatment decisions immediately, or the elevation may reflect an acute phase response and should be reassessed after recovery, or the patient requires anti-inflammatory therapy? What do you think? Okay, so 79% says that this is an acute phase response, which is correct. So when should you repeat it? So after an acute event, you should wait about 2 to 3 weeks before measuring high sensitivity CRP, because in an acute MI, you're going to get an elevation, and you shouldn't use this measurement to estimate, long-term decisions on therapy. So this is just a transient inflammation after an MI. Okay, so a patient with established ASCVD has a high sensitivity CRP is 4.5 despite receiving standard lipid-lowering therapy. What is the most appropriate current management approaches? Ignore the high sensitivity CRP results because LDL cholesterol is controlled, or you would intensify standards of care and optimize lifestyle interventions. Do you start antibiotics, or do you repeat high sensitivity CRP every week? So let's vote. Excellent. So 83% says we intensify standard of care and optimize lifestyle intervention. And that goes to say that even without therapy right now, there is something you can do about the results of a high sensitivity CRP. You can, and it's motivating for the patient, because when you give them a lab test, like usually patients, sometimes, they're difficult to convince, but you give them a lab test or you give them a calculator. This is what I know from practice. Like either I plug it in a calculator and I show them the numbers, or I show them a lab test, and they become more motivated to do all the lifestyle interventions that we know they should do anyways, right? They're ASCVD patients. They should control their weight. They should stop smoking. They should exercise, and they should diet. But for some reason, after the MI passes through and they're living their normal life, they feel like they do not need all these, they feel they're normal, and they don't feel like all of this is important. So when you show them a blood test, then they get more motivated. So even with the lack of current therapy, We know that targeted therapies are coming in the future, but it's important to test it. It's important to inform the patients about it. And it's important overall to estimate the risk. Like when I see patients in the clinic, I put it as a diagnosis. So an elevated high sensitivity CRP, I put it as a diagnosis. So it remains in the chart, and everybody who sees this patient later knows that this is a high risk patient. Like I would put elevated lipoprotein little a, even though we don't have therapy for this right now, but because that makes this patient high risk. Like I would put non-compliance to therapy. We don't have therapy for non-compliance, but you need to know, it flags the patient for you and for every other physician that this is a high-risk patient that we need to think about differently. So which assay would you use to identify cardiovascular inflammation? Standard CRP, high sensitivity CRP? Would you use a wide range CRP with low-end analytical performance, or is both 2 and 3 are acceptable? Okay, so we get a split. Half of you said high sensitivity CRP, the other half said both 2 and 3. So actually both 2 and 3 are acceptable. It was in Dr. Sharma's slide, but I think he didn't emphasize it too much, but it was there, he mentioned it. So we said high sensitivity CRP is the preferred method over CRP, because if you measure CRP, you're not going to get into these lower numbers that indicate inflammation but not infection. So you need to do high sensitivity CRP. A validated wide range CRP will catch levels that are indicative of low inflammation and high inflammation. So it can cover a wide range, basically. This is how it's called, wide range, a wide range of level of inflammation. But conventional CRP assays are not useful because they usually detect above 5, and this above 5 is for infection. It's not really for cardiovascular inflammation. So maybe because wide range CRP is not not available everywhere. I don't have it in my hospital, so maybe that's the reason. The other half answers have high sensitivity CRP, but it's good to know. Like if you get it from another hospital, it's good to know that it's reliable. Okay, so that was the end of my talk. I'm going to leave this slide for Dr. Nadia, and I'm gonna move on to her so she can moderate the question and answer session.
Thank you, Dr. Juwaria and Dr. Sharma, for the presentation and talk. So now we're going to start with the questions. I have a couple of the questions and discussion, and we have also from the chat couple of questions, Q&A, couple of questions. But I will start with the last question. Like one of the question they asked about, what do you see as the main barrier to implementing the high sensitivity CRP testing in the practice? So what do you think will be the main barrier?
The main barrier, sorry, to CRP measurements?
Yes, in the clinical.
Wide range implementation.
Yeah, so so it's very interesting for this question, and I think that there's multiple issues across different regions that can affect things. So, for example, in Canada, oftentimes certain labs will swap out high sensitivity CRP and they'll just give regular CRP as an example, right? So if you don't specify high sensitivity CRP, you're just going to get a regular CRP, right? So this is something for us to really keep in mind, that that we could see that happening in our clinical practice. Other things include the fact that patients, when they come to see you in clinic, they're often fine, but sometimes something has happened recently. So they have upper respiratory tract infections, recent surgeries, et cetera, et cetera. So the CRP may be fluctuating. That's why, Dr. Jawaria, as you adequately mentioned, a lot of the guidelines say, if you see it elevated, consider repeating it again just to see and just to make sure, to see if it's persistently elevated in terms of the CRP. Sometimes cost can be an issue as well. HSCRP is not, is generally not very expensive as a test, but some regions may not have full access to that as well. So I think there's a wide variety of reasons as to why HSCRP may or may not be available in certain regions and why there may be barriers to that. But I would actually love to hear it from your side. What would you see as the barriers within your communities?
I think for the UAE, one of the main barriers is we order the blood test 3 months ahead of, So like you've seen the patient, you order the blood test, they're going to come after 3 months. They're not going to remember not to do the blood test if they just had a recent infection. Nobody's here. I mean, they hardly remember to be fasting for the blood test. So that's an issue, because if they did it when they had a recent infection, then you have to repeat the test. And then when you're going to repeat the test, are they going to remember also to do that? So that becomes a little bit tricky to do. The other thing is it's not widely tested. It's not in the mind of the physicians, right? We think about LDL. We started to think about lipoprotein(a). It wasn't there in the mind, and now you have to remind yourself to also test for high sensitivity CRP, and that requires a lot of education. Like, we have to just remind ourselves that this is important. It will risk stratify our patients. We really need to understand the patient very well in order to inform the patient and ourselves what level of risk they are in and how to treat them in the future. I think the other problem would be is, if it comes high, what do I do with the patient? And that becomes sometimes an issue if you have a patient who is like going to read all these tests and then going to look them up on Google and then come with you with 100 of questions. But I think knowing is better than not knowing. And that type of patient is always going to be there. And I think they would appreciate better if you did a full proper evaluation for them than if you didn't do it. So I think that these are like the main things that I would see in practice that will hinder the physician from ordering it.
I completely agree. And often there's also a little bit of, there's multiple biomarkers that are now encouraged to be tested. Like if you have diabetes, to check for urine albumin to creatinine ratio. If you think of heart failure, NT-proBNP. If you think of inflammation risk, CRP. So there's just so many things to keep track of. It can sometimes become almost too much, right? Where there's so many things to test, and then what do you do if each one of these is elevated? So certainly that I completely align with you about some of those barriers being the implementation barriers overall.
Okay, there's also another question that's one of our attendees asked about any role of colchicine in such cases, the effect of different dyslipidemic and anti-failure agent on the high sensitivity CRP level.
Yeah, that's a really great question. Really great question. So we know colchicine, as I showed in my slides, actually is a fairly potent anti-inflammatory molecule. Okay, so it's been tested in several trials. The most prominent ones being Colcott and Ludoco 2. We think of colchicine as a very old drug, and in fact, it is an ancient drug. And sometimes, we say what's old is new again, right? So what we see in the past is often brought back in the future. But colchicine, which was previously being used, was recognized in its role as an anti-gout type of agent, and is often used in other types of autoimmune disorders as well. And so its ability, it actually targets the NLRP3 pathway. And that's the same inflammasome that produces the IL-6, the same inflammasome that produces IL-6, which goes to the liver to get CRP. So in fact, it is a part of the armamentarium. Overall, the trade-off with colchicine is potentially some of the side effect profiles. We do see a lot of diarrhea that's associated with colchicine therapy. You have to watch their neutrophil counts and infections as well. So there could be some hematologic side effects, infection risk, and diarrhea risk. GI, these are not insurmountable, but it certainly is there. And I think maybe these have prevented the widespread adoption of colchicine as an anti-inflammatory agent, but there is evidence, for these therapies.
Okay.
Yeah, I totally agree. I mean, colchicine is a valuable option, but as you said, they were limited by the side effects. But for sure, if you have someone with an elevated high sensitivity CRP, waiting for the new medications, and you're concerned about the risk, this is valuable information. I think part of the question was, does the other heart failure medication affect this? And
Yeah.
they don't. Yeah, so the heart failure medication will not affect it. Antilipidemic medication will not affect high sensitivity CRP. So statins, PCSK9 inhibitor will not have a significant effect on high sensitivity CRP.
Yeah,
So when
but certainly high sensitivity CRP is a good marker that we should be escalating, these types of therapies, because there's still benefit, right? And we do see some trickle effect of these therapies, on those. But you're absolutely correct that let's use the CRP as a marker to say, look, there's still inflammation. What else can we do? Stop the smoking, diet, exercise, weight loss, exactly as you mentioned. And if they're on a statin therapy, consider accelerating or increasing the dosing. The Jupiter trial, of course, enrolled patients with high CRP and that were very, very low risk, and it still showed a reduction in major adverse cardiovascular events. So completely aligned with what you're saying.
Yeah, exactly, because we're targeting the risk. So there are high risks. So you use these therapies not to reduce the high sensitivity CRP, but to reduce the patient risk. So
you use the patient risk, yes. And if CRP goes down, that's a good side. That's a good side benefit, right? Of that happening. Exactly. But we don't necessarily. CRP doesn't cause people to feel bad, at least not that we know of. It's really it's the risk marker that it implies, that causes it to go down.
Mm-hmm. So one more question. I think it's really a good question. How easy do you think it is to add a new therapy to an already complex treatment regimen for atherosclerotic cardiovascular disease and CKD patients?
I think about this. Go ahead, Dr. Sharma. But I think about this every time I order high sensitivity CRP in a patient and I look at their medication list and I was like, do I really want to know? But I think knowing by itself is important. So you know the risk, you document the risk. And then after that, you have the discussion with the patient. So some patients are not willing to take any extra medications, and that's fine. It's always a joint decision. But some patients are very invested in reducing the risk. So if they are very invested in reducing the risk and they are willing to go for the next, for example, right now we're talking about colchicine only because we do not have the new medication, then yes, then it's a joint decision making, and yes, you would go ahead and you would add a therapy. So I think it's going to depend on every patient, but I truly understand what they're saying. Like every time I order it, I look at the medications and like, am I going to add another therapy? But we're reducing risk as well. Like you're reducing the next MI that can be worse than the first one, that can lead to heart failure. So it's not a small thing. It's a major thing. But I also understand the point of view of the patient, like too many medications. Am I going to take all of them?
Absolutely. Absolutely. I mean, that's yet another tablet on top of, or another injection on top. So this is where that patient-centered discussion comes from. And I'm just seeing a question here. It says, doesn't statins lower hsCRP and colchicine? So statins in the randomized trials, we will see reductions in those levels. But what we want to clarify that you don't necessarily have to track those levels, as to follow the patients along. It's a risk marker. Let's address the risk. But in terms of following the patients over time, we don't necessarily have to track, let's say, the CRP over time. If you know that there's a patient who showed good compliance and it is adhering to medications. So just to clarify some of those that question, but with regards to pill burden, it's so real. Patients don't want another tablet. Sometimes increasing the dose is not that big a deal, because it's the same medication but a higher dose. So we'll have to see where will some of these novel anti-IL-6 therapies come on board with regards to then if these trials are positive, where will this come on board overall? So that's something we're waiting to see.
Yeah, like in heart failure patients, like you used to give only triple therapy, and then after we add the quadruple therapy, we discuss with the patient usually the risk and the survival. And nowadays it's easy to convince patients, especially if you educate and discuss with them the risk and the survival benefit. So maybe one of the last question, this question, what to do if a high sensitivity CRP is above 10, and does that mean the patient has inflammatory? That's why their high sensitivity CRP is high? Because they ask about the cutoff. If it's
Yeah.
above 10. Yeah.
Yeah. So I think we both mentioned it, Dr. Sharma and
Yes.
me. So anything with the levels of 10 and above, it means
Yes.
that there is either an inflammation or another cause. There is another
Oh.
cause for this elevation. So generally, you would see the patient screen for inflammation, screen for infection,
Yeah.
or any other reason why it's elevated, and then you would repeat it after a while just to make sure that is this really just inflammation, chronic inflammation. But it's unlikely to be just chronic inflammation with these levels. It's usually chronic inflammation is with levels lower than this. Yeah.
Completely agree. If you're seeing levels above 10, I think a thorough evaluation of the history and physical to see if something has happened recently. Has there been any sick contacts, upper respiratory infection? There's just something else probably going on if you have CRP levels that are that elevated. Completely agree.
Okay. Maybe the last question. If any effect of PCSK9 on the high sensitivity CRP? They asked before in the statin, now PCSK9. Do you think any? Yeah.
That is a good question. In general, it's not a very well studied area. We do see that there's still very high residual risk of having high inflammation despite being on PCSK9 inhibitors. So the POSEIDON data showed that actually quite nicely. And it alluded to that there was some small proportion of individuals that had PCSK9 inhibitors, but unfortunately, PCSK9 inhibitors are not very widespreadly used where we are. I'm not sure about in your region. I would actually be curious to hear. And so I think more data would be needed to convincingly show that PCSK9, really drops hsCRP. But prior studies, statins are really the core in terms of how do we reduce CRP and how do we reduce inflammation risk? It's statins.
Yeah.
Processing.
Yeah. So maybe last take-home message from Dr. Sharma and Dr. Juwairiya. Last message from you to the attendings or the team. Do you like any advice or any recommendation from your side regarding using high sensitivity CRP to the participant?
So maybe go ahead, Dr. Sharma, and then I'll go at the end. Yeah.
Thank you. So I think I would have three takeaways. Number one is that POSEIDON shows that inflammation is much more prevalent than we thought, even amongst patients who are very well treated on therapies. So that even they're on therapies, they're looking good, they're not very sick, they haven't been in hospital. Almost 1 in 3, if they have a bit of CKD and ASCVD, or roughly 1 in 5, will have elevated inflammation risk, right? That's very, very high. So that's take home number one. Take home number two is that hsCRP is a good marker of future atherosclerotic cardiovascular risk and mortality. So it is not a non-specific marker. It is actually pretty specific for CV disease if measured in the right patients, especially the patient that does not have, let's say, acute infection or acute illness or acute issue. And then the third is that there are things we can do even if the CRP is elevated. And I think a lot of people are hesitant to order a test because they don't know what to do with the results. Completely understandable. But there are things such as encouraging someone to stop smoking. I've seen a lot of patients who were, when you show them the CRP, the impact of inflammation, and people understand the word inflammation, they say, oh, it's high. Stopping smoking is the most common way of doing that. Exercising, walking, going up on your statin therapy. There are things we can already do to reduce inflammation burden. And if these trials become positive, that will add another lever for us to use to reduce inflammation risk.
What I would like to just add, so POSEIDON was done globally, but you see that the Middle East area was empty. So we have done POSEIDON in the Middle East. So we have Inflame East study that's going to be, the results will be announced in the ASC meeting. But I encourage you all to attend. I'm not going to give you any any heads up.
Mm.
But it's still very important to measure high sensitivity CRP in our population, like the overall world. You need to know the risk of the patient, because that can drive lots of the assessment that you're going to do. So attend ESC, see Inflame East. That's going to add up to the information that was presented about Poseidon, and think about high sensitivity CRP when you see your patient. Next.
Yeah, thank you so much. So we have now come to the end of our webinar, and thank you all for joining us today. We hope that you found the session informative and valuable, and a special thank you for our speakers, Dr. Sharma, Dr. Juwaria, for sharing their expertise and insights. And we appreciate your participation and looking forward to seeing you at our future webinars. Thank you and good night.
Thank you. Good night.
Thank you.